Thank you. I thank MSN Labs for organizing this session on ulcerative colitis. As we know that ulcerative colitis is a very interesting. For many years, there were not many drugs which were being used, but now we have a plethora of drugs which can use for treatment of ulcerative colitis. I am Dr. Kunal. I am Senior Consultant Gastroenterology and Hepatology in Manipal Hospital, Dwarka. So the objectives of my presentation is to describe the relationship between JAK-STAT signaling pathway and pathogenesis of ulcerative colitis, to incorporate evidence-based research into clinical practice. That is the objective of today's session. So, as we know, ulcerative colitis is an autoimmune, relapsing, remitting chronic disease of the large intestine, in which the lining of the colon becomes inflamed and develops tiny sores or ulcers. This is the normal colon, and this is the ulcerative colitis colon, where the surfaces become ulcerated. They are in between the normal surfaces. They are also present the ulcerated surfaces. In the ulcerative colitis patient has chronic inflammation of the large intestine, which further triggers the symptoms of ulcerative colitis, which are recurrent diarrhea, abdominal pain and cramping, fatigue, weight loss, blood in stools, intestinal blockage or sores. The prevalence of ulcerative colitis is around 44 per 1 lakh. So typically, ulcerative colitis patient will present as a bleeding PR, recurrent or once or twice, or may have typically patient will say a very urgency of stools, that the patient has to run to the stools and many times in a day, maybe 4 or 5 times, and sometimes the initial part there may be some more stools, and in the subsequent there may be no shows even. Factors which cause ulcerative colitis. The factors which cause ulcerative colitis include some genetic factors, immunological factors, and environmental factors. It is overall an autoimmune disease, etiology of which is unknown, but we can speculate. The genetic factors, such as some gene mutations, HLA types, or chromosomal changes, may be there. In them, it is found that ulcerative colitis has increased prevalence in them. There are certain environmental factors such as bad eating habits, junk food, spicy food, lack of fiber in food, or poor lifestyle. They cannot cause ulcerative colitis, but in a patient of ulcerative colitis, they can make them symptomatic. There are always immunological factors such as autoimmune diseases in relation to other autoimmune diseases like PHC or thyroid or even diabetes. And also there is some change of blood flora, or reduced blood flora may be present. These days, there have been a lot of studies on the microbiome of the colon, and which may be one of the factors in causing ulcerative colitis. So how do we, once we have diagnosed ulcerative colitis, how do we grade the ulcerative colitis? How do we clinically grade? It is clinically graded as mild, moderate, and severe. Mild disease is one where there is rectal bleeding, but the bowel motions frequency is less than 4 per day. It may be only initial damage of the mucosal layer of the large intestine, maybe only the rectum is involved. Second is moderate grade, in which rectal bleeding is there and the frequency of motions is 4 to 6 per day. Here, there may be increased cytokine levels due to tissue damage and recruitment of inflammation or immune cells, which results in inflammation and further tissue damage. Whereas there may be certain cases where it is very severe, the rectal bleeding is there, and the frequency of bowel motions is more than 6 per day. And there is also systemic response syndrome, systemic illness, along with a hypoalbuminemia of less than 30 grams per liter. In this case, in severe, there may be exaggerated cytokines, which triggers further overstimulation of immune cells, leading to chronic inflammation and ulceration across the linings. So coming to now, once we have diagnosed, what are the complications of ulcerative colitis, which we have to be aware of? There may be certain complications which are acute in nature, which come suddenly on the diagnosis of ulcerative colitis, maybe at first presentation, or already a known patient of ulcerative colitis may present with a severe episode or an acute episode clinically. The most dangerous of all complications are toxic megacolon, which is a life-threatening complication. Here, the colon is dilated, and if you do a simple X-ray of the abdomen, we'll find that the colon is dilated the maybe more than around 8 centimeters in the transverse colon. It may lead to perforation. There may be hemorrhages. What are the chronic complications of ulcerative colitis that we must be aware of? The most important is that it can cause colon cancer. The frequency of colon cancer is 20% in 20 years. So we have to be aware of this, and we have to tell our patients accordingly that you should get your colonoscopies every 5 years or so that we can look out for any changes which can be suggestive of cancer. There are certain extra intestinal manifestations that are very important, and we must be on lookout for them. The most important are the skin lesions, the eye issues, and the liver disease, which may be associated with ulcerative colitis. Next slide, please. Now, coming to a short about the pathogenesis. Under physiological conditions, there is usually a general hemostasis which is there. Normal microbiota in the intestinal lumen. There is the mucus layer, there is the epithelial barrier, and there is a laminar propria which is there. The commensal gut flora is there. Epithelial cells that line the interior muscles of the interior of the intestines, and the immune cells within the tissues which are there. So when there is this homeostasis is disrupted in a susceptible host, there may be certain specific environmental issues like diet, antibiotics, enteropathogens, stress, which may lead to disruption of this homeostasis, leading to the clinical presentation of ulcerative colitis. There may be certain genetic factors. The whole genetic factors, there are a whole lot of genetic factors involved, which include NOD2, ATG16L1, IRGM, IL-23 receptors, FUT2, and cardiology CARD9. This results in hyperactivation of T helper cells, TH1 and TH17 cells. This increases the tight junction permeability and leads to uncontrolled chronic inflammation, leading to presentation of ulcerative colitis. Now, this dysfunctional response from the innate and adaptive system, the environment triggers, the microbiota, the epithelial barriers, the non-epithelial barriers, the genetic predisposition, the mucosal immune system, they all come together, leading to multiple inflammatory cytokines which are overexpressed during an episode, leads to amplification of the immune response, leading to phenotypic expression of disease and tissue destruction. These cytokines mediate the dysfunctional cell-cell interactions in the innate and adaptive response system. These days, because of the corona episode, people are very concerned, and they understand the cytokine storm which is there, which is the key for all many of the diseases that we are facing today, including. So this is the schematic diagram of the colon, where the epithelial cells are there, the mucinous cells are there, the commensal microbiota are there, which are non-pathogenic. First, there is a disruption of the light junctions and the mucous film over the epithelial layer. The mucinous, which is a protective layer, this is impaired, and this defective regulation of the tight junctions. This causes increased permeability of the intestinal epithelium, resulting in increased uptake of luminal antigens. Once the luminal antigens come into being, the circulating T cells, which bear the integrin levels alpha 4 and beta 7, bind to this colonic endothelial cells microvasculature through the mucosal adhesion system, adhesion molecule 1, whose expression is enhanced. This leads to the upregulation of the inflammatory cytokines such as CXCL1, CXCL3, and CXCL8, leading to recruitment of further leukocytes, which perpetuates the cycle of inflammation which is there. So, after understanding the pathophysiology, now we should understand what are the treatment goals. Before treatment goals, I will say one word about how do you diagnose a case of ulcerative colitis. The ulcerative colitis is diagnosed whenever a patient comes. Simple, you have to do some blood tests, which include CBC, ESR, CRP. You can do a simple X-ray abdomen. Once you have satisfied yourself that there is no toxic microcolon, you can go ahead and do the stool test, stool routine microscopy, followed by colonoscopy. Colonoscopy will tell you endoscopically the inflamed mucosa, and if you do a biopsy on colonic biopsy, you will find that there are features of chronic inflammation and crypt disruption, which makes the diagnosis of ulcerative colitis. Also, by doing a colonoscopy, we know the extent of ulcerative colitis which is present, whether it is only in the rectum or in the left-sided colitis, which is E2, or it is pancolitis. Pancolitis is the most severe form of ulcerative colitis. So, what are the treatment goals which of the ulcerative colitis? First and foremost is the induction of remission. Second is the maintenance of this remission. And third is prevention of complications, therapy-related allergies, intolerance, infections, lymphoma, steroid side effects, and disease-related extraintestinal manifestations, neoplasia, and toxic megacolon. So this is we have a whole lot of ulcerative colitis drugs which are being utilized, which have been for in the last 7 decades. Starting from aminosalicylates like sulfasalazine, which is a prodrug, nitrosamine, and balasalazine. Corticosteroids, these days, again, steroids are in the focus. We have both the prednisone, the dexamethasone, and also some of the newer steroids which are less toxic, like budesonide. Also, we have the immunosuppressants, which we like azathioprine and methotrexate, which are being utilized. Antimicrobials, in a case of active disease, we might need to do antimicrobials, which include metronidazole, ciprofloxacin, doxycycline, and many others. TNF alpha inhibitors, these are the second or third line drugs to be used, biologicals, infliximab and adalimumab. They are very useful, especially in certain conditions. But at the same time, you have to be careful what you are utilizing. There may be specific indications, and also there's an expense which is attached to it. Then there are the JAK inhibitors, which we will discuss, and Dr. Chaudhary will discuss in detail. And the last but not the least, the surgery. There's always special, although it's not part of the discussion today, but there is always a certain category of patients whom might need an emergency surgery or an elective surgery for treatment of ulcerative colitis. So coming to the medical treatment first. First category, which is the most common category, is the 5-ASA or 5-aminosalicylates. Here we have seen that the preparations include sulfasalazine, which by the bacterial flora and the bacterial azoreceptors is split into sulfapyridine and aminosalicylic acid. The sulfapyridine is rapidly absorbed. It doesn't have any therapeutic action, and but sometimes may have a systemic adverse effect of being allergic and other things. So alpha 5-ASA and its congeners acts through the lumen, which are poorly absorbed and has an anti-inflammatory action, leading to remission of ulcerative colitis. The aminosalicylic acid inhibits the COX pathway, the LOX, PEF, bacterial adhesion factor, cytokines, and also inhibits IL-1 and TNF alpha. So the preparations of ASA are sulfasalazine and mesalamine. They are effective in reducing and maintaining remission. Topical mesalamine can sometimes be used in suppository form, especially for symptomatic relief, as well as it's very useful in cases of ulcerative proctitis, where the disease is limited to only the rectum. Left-sided colonic disease is also best treated with combination of mesalamine suppository and an oral aminosalicylate. Next in line are the corticosteroids. These are one of the mainstays in initiating remission. They are used in the acute treatment of moderate to severe colitis. They include both IV preparation as well as oral preparation. Budesonide is a new glucocorticoid which is entirely released in the colon, has minimal to no systemic glucocorticoid side effects. Dose of 9 mg per day for 8 weeks and no tapering is required. Also, in the acute phase, rectally administered steroid enemas may provide a very good symptomatic relief, especially for fears of distal UC. The corticosteroids act by this pathway, the GR pathway, the GRE, the gene transcription, the CRP hat, and mRNA, the anti-inflammatory protein are being produced by the corticosteroids. Now, next line of drugs is the thiopurines, which are quite effective in maintenance of remission. They are, but the thing with thiopurines is that they are not appropriate as solo induction agents. Usually, they have a very slow onset of action, requiring 2 to 6 weeks for their action, and they are used for mainly which are very severe disease or steroid dependent or steroid refractory disease. Uh, the preparations which are available in the market are azathioprine or 6-mercaptopurine, and this is an important pathway by which they are utilized. Azathioprine, the 6-mercaptopurine pathway, and SGPRT, CGMP, and leading to apoptosis. This is the mechanism by which they are putting into action. Next in line is cyclosporine, which is more of a drug being used in renal transplant and liver transplant cases. But it is used as a third line drug with severe ulcerative colitis, 2 to 4 million per kg per day as a continuous infusion. But it has serious side effects in the form of nephrotoxicity, opportunity infections, and seizures. This is the pathological mechanism by which the cyclosporine pathway acts by the calcium channel blocker pathway. Now, coming to the biologics, which are the anti-TNF alpha antibodies. They are IgG monoclonal antibody that is against anti-TNF, TNF alpha. It's a less toxic alternative to cyclosporine for patients with severe steroid refractory disease, effective for both induction and maintenance of remission. And preparations include infliximab, which induction remission is 5 mg per kg body weight, and giving in weeks 0 to 6. Maintenance dose is 5 milligram per kg body weight, IV every 8 weeks. So this is the pathway by which they use. There are also newer biologics like natalizumab and vedolizumab which are being used, but they are mostly very useful for especially Crohn's disease, which have fistulizing Crohn's disease. So another therapy which is very important these days is especially in refractory disease is fecal microbiota transplantation. This has been, but still it is a research-based therapy protocol, and it is not still conducted in very few studies and the research protocols, and still not in a and there is no capsules. It is only in a few centers it is available. I will just borrow 2 slides from Dr. Chaudhary's presentation. Rationale for targeting JK-STAT pathway. These are the new drugs which will be discussed in detail by Dr. Chaudhary. JAK plays a role in cellular proliferation, differentiation, and immune functions. JAK-STAT is a major signaling cascade downstream for cytokine and growth factor pathways. The JAK family is JAK1, JAK2, JAK3. JAK-STAT is 7 transcription factors. JAK serves as transducer signals from cytokine receptors. JAK inhibitors interfere with JAK-STAT signaling. JAK inhibitors are usually effective in other chronic inflammatory conditions. This one I want to that why JAK-STAT pathway signaling drugs have come into ulcerative colitis, because many of the our rheumatology friends, especially in rheumatoid arthritis, psoriasis, these are the autoimmune disorders which are of the skin as well as the joint, are being utilized these drugs for a very long term with very good results. So JAK inhibition is a potential therapeutic target in ulcerative colitis, and Dr. Chaudhary will discuss the details for the same. Thank you very much.